Hello, I'm Dr. Wright, and this session on bronchiectasis is part of the Lung Pathology in Easy Bite series. As in the previous sessions, they are directed towards medical students and junior pathology residents, although other healthcare professionals might find them useful. As always, I welcome your comments, and I hope that you enjoy the series. Hello, I'm Dr. Wright, and this session on bronchiectasis is part of the Lung Pathology in Easy Bite series. Our learning objectives are firstly to define the term bronchiectasis, understand the various possible classifications, site, morphological, quasi-etiological, and finally to understand the pathology of bronchiectasis. The definition of bronchiectasis is thusly: an irreversible dilatation of the bronchial tree, and this dilatation is present in all phases of respiration. It can be due to traction from adjacent fibrosis, as in interstitial lung disease, direct obstruction of the airway lumen, alteration of the mucus, alteration of the cilia, and alteration of the bronchial wall. And I'm going to address it in this kind of sequential fashion. Here are possible classifications. There's a morphological classification of cylindrical, varicose, and saccular, which roughly corresponds to severity. You can classify it as to site, proximal, or distal. That doesn't really help you very much in identifying the etiology of the bronchiectasis. Or you can address it in a quasi-etiological fashion, and that's the fashion I've chosen to illustrate to you today. So, traction, idiopathic, and post-obstructive. Let's start with those three. Idiopathic, there are two conditions in here. It's debatable whether they're actually acquired or congenital. Tracheobronchiomegaly, also known as Meunier-Kuhn disease, where there is elastic fiber and muscle loss, and Williams-Campbell syndrome, in which the third to the sixth generation of cartilage is either reduced or actually absent, and post-obstructive due to a variety of changes. I'm particularly irritated by the term Lady Windermere's syndrome for middle lobe syndrome, because anyone who has actually read Oscar Wilde's play knows that Lady Windermere was not being fastidious when she refused to shake Lord Darlington's hand. She was just angry at Lord Darlington and didn't want to shake his hand. Let's start off here with traction bronchiectasis. Here is a gross photograph of a patient with interstitial lung disease. In fact, this is usual interstitial pneumonia, where you can see quite clearly that there is dilatation of the bronchial tree in this area of rather dense fibrosis. This is recapitulated here in a CT scan, where you can see subpleural fibrosis and extensive traction bronchiectasis as indicated by the red arrow. Here is a CT scan which shows tracheobronchiomegaly, and here just plain tracheomegaly. And here is a case of Williams-Campbell syndrome, in which the third to the sixth generation of airways are markedly dilated. Here's an illustration of post-obstructive bronchiectasis. In this case, there's a proximal tumor and distal bronchiectasis. You can note the marked degree of mucus plugging here. And this is a case where there was an inhalation of a plastic foreign body and subsequent quite marked bronchiectasis as a result of this. Other etiologies of bronchiectasis include alteration of the mucus, particularly in cases of cystic fibrosis, with alteration of the cystic fibrosis transmembrane receptor, and the cilial dyskinesia syndromes, including the primary cilial dyskinesia syndromes and Young syndrome. Here is a gross specimen from a patient who died with cystic fibrosis, showing really quite marked bronchiectasis, and here's a Goff section, which again illustrates this pathology. The cilial dyskinesia syndromes, I'm sorry I don't have a picture which illustrates that, but here is an electron micrograph showing the substructure of a cilia, and this is altered within a cilial dyskinesia syndrome. If that is altered, then the cilial beats become altered and mucus cannot be taken on the escalator up to the proximal airways. Alteration of the bronchial cartilage is quite a prominent feature of bronchiectasis, and this can be post-inflammatory or post-infectious, tracheobronchopathia osteoplastica, tracheomalacia, amyloid. You've heard about Williams-Campbell syndrome, relaxing polychondritis, and immune defects, as in the following. This is a case of tracheomalacia seen in a patient who had been intubated for a very long period of time. Note that the cartilage is abnormal with central degeneration and perichondral fibrosis. This is a case of tracheobronchopathia. Here's the gross specimen showing these little nodules of cartilage which are growing out from the cartilaginous rings and impeding the mucus escalator. This is an X-ray which again shows this. These are the cartilage rings which are relatively normal, and here are these little exostoses coming out from it, which is exactly what tracheobronchopathia is, are little bony exostoses coming off of the cartilaginous rings. This is a case of relapsing polychondritis. The cartilage is involved throughout the body. In this case, there's some rather droopy looking ears, and this is a lung which shows massive alteration of the cartilage due to this inflammatory response. It's a direct inflammatory response against the cartilage, so that there is marked cartilaginous degeneration, showing here on this low power, and on a higher magnification, the inflammatory infiltrate, again directed towards the cartilage. This is a case of HIV-associated bronchiectasis in the absence of infection. So there must be some sort of immunological defect that allows patients with HIV disease, regardless of infection, to develop bronchiectasis. This is another puzzler where there is bronchiectasis in patients with alpha-1 antitrypsin disease, probably associated with inflammation, although the point is debatable. Here are some examples of post-infective bronchiectasis, which were much more common in the early part of the 20th century, and I presume that there will be little outbreaks because of the problems related to infective outbreaks after loss of vaccination immunological help. So this is an illustration of measles bronchiolitis, in which case the airway epithelium has been completely destroyed with these large measles giant cells. This is a patient who had a fungal-induced bronchiectasis. Inhalation of noxious fumes or gases can certainly be associated with bronchiectasis. In World War I, there was nitrogen mustard, and the soldiers came home with a fair degree of bronchiectasis. The other ones are usually in an industrial accident or a home accident. This is a case of a child who actually inhaled kerosene and developed upper lobe bronchiectasis. The pathology of bronchiectasis is similar, regardless of etiology. So the airway is distorted to a variable degree, as in saccular or varicose bronchiectasis. It may or may not contain mucus. It may or may not contain inflammatory cells and debris. The epithelium shows the usual metaplastic changes of goblet cell metaplasia and squamous metaplasia, and the interesting change of Kolchitsky cell metaplasia. I'll show you these. You know that the diameter of the airway should be relatively similar to the diameter of the adjacent vessel, so that you can tell quite easily that this airway is bronchiectatic. In this case, there's fibrosis and inflammation, but no mucus plugging, no great degree of luminal inflammation, small mucus plugs out here. This would be called so-called dry bronchiectasis. These illustrations are so-called wet bronchiectasis, where there is extensive mucus plugging and a lot of surrounding inflammation, and in this case, there's actually a purulent exudate within these destroyed bronchi. These are illustrations of Kolchitsky cell metaplasia, and here are the neuroendocrine cells, which are hyperplastic and surround this small airway, and here they've actually formed a little tumor plug. Occasionally they can get large enough to be called carcinoids. So the pathology of bronchiectasis can be sequentially examined. So that there's plugging of the lumen of the airway, there's cartilage degeneration or actual destruction, and in the wall there's inflammation, fibrosis, and loss of elastic fibers. This is true regardless of the initial etiology of the bronchiectasis. Complications of bronchiectasis: obviously, repeated infections. This is certainly true in patients with cystic fibrosis. Airflow obstruction, actual hemorrhage when the inflammation destroys the bronchial arteries, and sometimes patients can actually exsanguinate as a complication. And colonization by fungus, giving aspergillus balls. This is an example of an aspergillus ball filling this bronchiectatic cavity. Here's a smaller one here. So the learning points of this session were firstly to identify the definition of bronchiectasis, the possible classifications with an emphasis upon etiological classification, and recognition of the various pathologies found in bronchiectasis. Here are your questions. Question number 1. The answer to question number 1. Question number 2. The answer to question number 2. Question number 3. The answer to question number 3. I hope you've enjoyed this session on bronchiectasis.